That's a really nice response. We don't usually get that. I appreciate that. So good afternoon. My name is Ben Harris. I'm Vice President and Director of Economic Studies here at Brookings. Welcome to this event on the lessons from the collapse of Steward Health Care. Thank you, obviously, for joining us at this event in person, and for those online, we welcome you as well. At today's event, we'll try to better understand the factors underpinning the tragic collapse of a major hospital system. In addition to hearing from renowned experts and policymakers, this event will present Brookings' findings on the role of regulation in enabling Steward's downfall. If you have not yet read the paper released last week, I strongly encourage you to do so. The research provides an evidence-based narrative of the collapse, chronicling the problematic combination of bad actors and insufficient oversight. The paper concludes with a thoughtful presentation of policy remedies. I should note that I fully expect Brookings to do more work in this area. All right, so let's just get to it with the event. We're thrilled to host opening remarks by the Honorable Chris Murphy, the junior senator from Connecticut. The senator has represented his state since 2013 in the U.S. Senate, where he is, among other roles, a member of the Help Committee. Senator Murphy has a keen interest in the way that private equity can affect hospitals, since 3 hospitals in Connecticut were owned by a different health system, Prospect Medical Holdings, that, like Steward, recently declared bankruptcy. Less than 2 months ago, he issued a report, A Dangerous Prospect, How Private Equity Decimated Connecticut Hospitals. We look forward to hearing from the senator shortly as soon as I conclude. Then following the senator's remarks, we'll hear from Amy Goldstein. Amy is a visiting fellow at Brookings in the Center on Health Policy and the Center for Economic Security and Opportunity. Amy came to Brookings following 3.5 decades as a staff writer at the Washington Post, where she wrote extensively about healthcare and other social policy issues. She is the author of Janesville, An American Story, which is a close-up portrait of a small Midwestern city that lost thousands of jobs during the Great Recession when the oldest operating GM plant shut down. Here at Brookings, she is the lead scholar on her case study of Steward. Following Amy's remarks, we'll have 2 panels to discuss the issues raised by Steward's collapse. The first panel will focus on the ground level view of what went wrong. The second will focus on the policy view. Moderating both panels will be David Wessel. David is a senior fellow at Brookings in Economic Studies and director of the Hutchins Center on Fiscal and Monetary Policy, and he will introduce our 5 panelists. So I very much look forward to the discussion today and hope you do as well. Senator Murphy, over to you.
Great. Can you hear me okay?
Yes.
All right. Wonderful. Well, I apologize that I'm not there with you in person. We are in the middle of a series of votes attempting to reopen the federal government unsuccessfully. Pretty hard when there's no actual negotiation happening. Very difficult when the House of Representatives is not even here in session. But I really appreciate you bringing together some super smart people to talk about how right now private equity is decimating our nation's hospitals, other healthcare institutions in our communities, how it's lowering the standard of care for millions of Americans across the country. Congratulations to Amy and Vanny and everybody at Brookings for the release of this new report. And again, grateful for the invitation. In August, I released my own report to tell the story of how one private equity company in Los Angeles called Prospect Medical Holdings had destroyed healthcare for thousands of low-income patients at 3 hospitals in Connecticut. I talked to a lot of healthcare workers and patients at those 3 hospitals. It's Waterbury Hospital, Rockville Hospital, and Manchester Memorial. And they told me and my staff about how Prospect, came in, typical of a private equity firm, made big promises about the major investments they were going to make in these hospitals, but instead the exact opposite happened. Prospect, essentially stripped these hospitals bare so that they could flip them very quickly based on a highly leveraged financial transaction. They skimped on supplies, they cut the workforce, they prioritized short-term profits over patient outcomes. Surgical techs talked to us about how patients were left on the operating table without the required materials to sew them up. There were rusty stretchers, there were loose IV cords. I mean, it was just a disaster. One woman at Manchester Hospital died giving birth because an emergency C-section was done too late. All of this horror so that Prospect's CEO and his investors could become filthy, filthy rich. Now, the staff at those hospitals did everything that they could to keep the care as good as they could. They were heroic. They still are performing miracles, but ultimately they couldn't perform miracles with nothing. Um, I'm proud to report, though, that in part because of our advocacy, these three hospitals are now in the process of being turned over to nonprofit entities instead of cycling through another private equity firm. So to me, this is simple. We we act as if we have to just accept that the motivating factor in our healthcare system should be rapacious greed instead of taking care of people. But why should we accept this? Why do we accept that our hospitals and our nursing homes are just vehicles for the enrichment of the 0.01% crowd? Why should our grandparents be pawns in a game designed to let private equity executives compete with each other in a game of who has the biggest private jet? Like that's dystopian. That's disgusting. And it's just our choice as a society and as a government as to whether we should allow it. And it's important to remember that it wasn't always like this. I think a lot about the insurance industry. Today we accept that the insurance industry is just big business, but you know, and that frankly, the motivation is not to care for people. It's frankly to deny people care, to drive people crazy trying to get reimbursement for care. Again, all in order to let investors and owners of these insurance companies live lives of luxury. Multiple vacation homes, yachts, fancy cars. Well, people are desperate for care. But where did the insurance industry start? It started during the Great Depression, when people were having a really hard time paying their bills when they got sick. And so the administrator of a hospital in Texas, Baylor University Hospital, comes up with an idea. He just says, why don't we start with teachers, who he noticed, because he was a former teacher, he noticed that teachers were having a particularly hard time paying their hospital bills. And this was also a problem for Baylor because they had a lot of unpaid bills that they were trying to collect on. So times were hard for the hospital, times were hard for these teachers. And so he creates a plan for about 1,250 school teachers in Dallas to pay 50 cents a month. And that would get them basically 21 free days of hospital care. It was just a way to help people afford care. And yeah, sure, the hospital was helped by reducing the amount of unpaid bills, but this was just about helping people. These Texas plans, they became the precursors to the Blue Cross plans. Ultimately, this was the nation's biggest not-for-profit healthcare insurer back when we thought health insurance was a public good. And that's what insurance was for decades. It wasn't a way to make profit. It was just a way to help people afford expensive care. Again, a public good, not a private source for excessive profit as it is today. We were looking back at the initial criteria that the American Hospital Association used to approve health insurance plans. And it's just wild that this was a world that we lived in for so long. The criteria was that the plan had to be not for profit. The plan had to be designed to improve the public welfare. It had to cover hospital charges, and it had to allow free choice of physicians. Again, that's just a world that doesn't exist today, but it wasn't so long ago when hospitals wouldn't deal with an insurer unless the plan was designed to improve public welfare. So what happened? What did we as a country decide so that healthcare was no longer a public good? The cancer medications, for instance, would be treated like a designer handbag. Some people can afford, and then other people just had to go without. Well, it was a series of decisions, and I won't go through the litany of them, but it's the passage of the HMO Act in 1973 that provided these unprecedented incentives for for-profit insurance businesses. It was Reagan's deregulation of the insurance marketplace. Healthcare became a really profitable business, and the not-for-profit healthcare industry just couldn't compete. And the predominant model became for-profit. I mean, I tell this story because we've become so desensitized to corporate greed in our healthcare system, that we forget it was ever different. Young people today have only lived in this system. They know it's fundamentally broken. They can feel it when they go to a hospital that's suddenly short on supplies, like these 3 hospitals in Connecticut, or when they go to an urgent care facility and they have to wait for 3 hours, or when they're booking an appointment online with the first available doctor instead of a primary care physician that they have a relationship that they know and trust. There's a soullessness, there's an emptiness to our current healthcare system now that the driving force isn't taking care of people. It's making a tiny number of people a disgusting amount of money. In my report, I talked really specifically about the lifestyle of the CEO of Prospect Healthcare. The craziest thing that I learned is that he has 2 mansions 11 minutes apart somewhere outside of LA. He's got 2 different mansions 10 minutes apart. And he's buying his second mansion at the same time that Connecticut hospitals are running out of supplies and the ceilings are crumbling. In the Brookings report, you talk about how Ralph De La Torre was attending equestrian events in France. Well, community members were out there begging for these hospitals to just be made safe. Private equity CEOs are worth literally billions of dollars, money made making healthcare worse for high need communities like Waterbury and Rockville and Manchester. That is fundamentally immoral, and we don't have to accept it. The good news, and I know you'll talk about this, is that it's not too late. 58% of hospitals in the United States are still not for profit. So we could make a decision to stop the hospital industry from becoming purely a for-profit enterprise, the way that health insurance did, right? It may be too late for health insurance. It's not too late for acute care hospitals. In Connecticut, as I mentioned, we are in the process of converting those 3 hospitals that Prospect ruined into nonprofit, community-centered institutions again. We've learned our lessons. We know that private equity doesn't just make healthcare more expensive. It doesn't just pad the pockets of wealthy investors. It actually makes care worse. The research here is pretty clear. It found, for instance, that patients at private equity-owned hospitals are more likely to get an infection. They're more likely to experience a fall. They're more likely to have a variety of adverse events following a procedure. There's another study of private equity-owned nursing homes, and this one is just damning. It shows that if you're a patient at a private equity-owned nursing home, you will have an 11% higher mortality rate than those that are not owned by private equity. So those are the stakes here couldn't be higher. This is literally a matter of life and death, in addition to being a question of whether or not we want to build a moral healthcare system, not a virtue barren healthcare system. So that's why I'm working on federal legislation right now to address this problem. And my legislation would keep private equity out of ownership stakes in our hospitals and nursing homes, so that in the future, what happened with Steward in Massachusetts and Prospect in Connecticut doesn't happen all over the country. And so to do that, we've got to have events like this. We've got to be willing to tell the stories of what happens to community hospitals and nursing homes and other healthcare centers that are bought by private equity and all the immoral outcomes that result. And political leaders on both sides of the aisle need to have the courage to stand up against these deals when they're proposed for their communities. This issue, I think, is representative of a broader political realignment that's happening all over the country. People on the right and the left are freaked out at the massive consolidation of control over our economy that's happening writ large, but they're particularly worried about that in our healthcare system. And so this is a place where you could see Republicans and Democrats stepping up and saying, oh, enough is enough. We are not going to let happen to our hospitals what happened to our insurance industry. We believe, based upon the data, that there's just no claim that private equity ownership in our hospitals, in our nursing homes, lead to better care. We know it doesn't lead to lower cost care either. So I really appreciate the work that you're doing at Brookings to dive into this issue. I'm looking forward to the conversations with experts that are going to happen today, all in the name of improving American healthcare and preventing hospitals and other healthcare institutions all over the country suffer from the fate that those hospitals in Massachusetts and our hospitals in Connecticut have suffered. So again, sorry that I'm not there with you in person, but looking forward to getting a full readout of this event. Thanks a lot for having me.
Good afternoon. I'm, as advertised, Amy Goldstein, and I really want to thank the senator for managing to make time to share his thoughts with us while he's right in the middle of a series of votes. And while I'm on the subject of thanks, this has really been a takes a village kind of a project. But I want to single out just a few people in particular. Kathy Minahan is a Brookings trustee, and she has generously supported this work with every meaning of the word support. It was Kathy who first approached Brookings and raised the question of whether anyone around here might be interested in taking a hard look at this company called Steward Health Care. So she, in a real way, was the genesis of all this. Richard Frank runs the Center on Health Policy. And when I first showed up at his doorstep, Richard told me he thought it might come in handy to have someone like me, which is to say a fairly nerdy longtime journalist, on the staff. And throughout this project, Richard has been an indispensable coach and sounding board. I also want to thank Vani Agarwal. Where are you, Vani? Vani has been my partner. She's a research analyst here, and Vani has been my partner in all things Brookings. She's somebody who possesses a real passion for policy that makes a difference to people. And she possesses excellent data skills without which the charts you're about to see simply wouldn't exist. So I'm grateful to you all. So to begin, those of us who are here in person are sitting in the nation's capital with the government shut down. But I'd like to transport you for a moment to Northeast Louisiana, and in particular to a town called Farmerville, where about 3,000 people live. One of those people was this woman. Her name is Merle Hodge. She lived in Farmerville her entire life, 90 years, until February of 2022. Early that month, Merle Hodge got COVID, and she was admitted to this hospital, Glenwood Regional Medical Center. 5 years beforehand, Glenwood had been bought by a private healthcare system called Steward Health Care. Merle Hodge was at Glenwood for 4 days before she died, but she didn't die of COVID. She died because of mistakes at the hospital, mistakes like a heart monitor whose electrodes were unattached, and a breathing mask that was just sitting on her stomach doing nothing, and no one checking even when a technician warned the nurses. She was found no longer alive by a granddaughter who had come to pay her a visit. We'll hear more about Glenwood from one of our panelists this afternoon, but for now, there are 2 points I'd like you to consider. The first is that by the time Merle Hodge died, Glenwood, like other hospitals owned by Steward, was running short on staff and medical supplies. The other point is that the Louisiana Department of Health received a complaint about what had happened with Merle Hodge and conducted an investigation afterwards, which is how we know about all this. Unlike some states, Louisiana has a law and a regulation that spells out fines when hospitals commit certain kind of mistakes. And the fine for this mistake that cost this woman her life was $1,750. This is the kind of thing that we learned working on this case study about Steward Health Care. And during the next few minutes, I'm going to talk a bit about Steward's background, how we thought about and explored what went wrong, and some preliminary ideas for what might help make other Steward-like sagas less likely in the future. So some background. Last year, the entire Steward health system filed for bankruptcy. It was a big bankruptcy. There were 31 hospitals in 8 states. Steward started out in Massachusetts, as we'll hear from one of our next panelists, and it marked a sharp break from that state's tradition of nonprofit hospitals. It was created in 2010 as a sort of rescue mission for a failing Catholic health system of 6 hospitals all around Boston. It was a for-profit system, and more than that, it was financed by a private equity company called Cerberus Capital Management. And 6 years later, Steward and Cerberus brought one more leg onto the stool, a real estate investment trust called Medical Properties Trust. MPT, as is known, bought the hospital buildings and their land. Steward got a lot of money from the deal, $1.2 billion, and over the next several years, it paid MPT an awful lot of rent. And with this threesome, Steward grew a lot, to 36 hospitals in 10 states at its peak. And it got into big trouble financially and trouble in ways that harmed patients. In May of 2024, the system collapsed, and since then, a bankruptcy judge in Texas has presided over the company's dismantling, with some hospitals eventually taken over by new owners and a few now closed. It has been very, very messy. So what went wrong? Well, Steward's collapse has drawn a lot of attention. As for the causes, much of it has been focused on a couple of factors. One is, as the senator was referring to in the context of a different health system, excesses by the company's top management. Steward's longtime CEO until a year ago, a cardiologist named Ralph De La Torre, is an appealing villain in the story. He was living large, taking payouts from the company, defying a Senate subpoena to testify about what happened. A second factor that's gotten a lot of attention is, as the senator also talked about, the role of private equity firms and their profit motive. We'll hear more on our second panel about private equity in different parts of the healthcare system, and the reasons that private equity can actually be appealing to health systems that need capital. As for our perspective, we started from the premise that various kinds of bad guys sometimes are simply going to materialize in healthcare. And our central question became this: when problematic actors take over hospitals, who is minding the store? That's fundamentally a regulatory question. And the bottom line we discovered is that regulation and oversight failed. It failed not just at one level. It failed at the federal layer, often involving the Centers for Medicare and Medicaid Services, but not only that agency. And it failed at states level as well, state health departments and attorneys general. And there were two kinds of basic shortcomings. Sometimes officials didn't have enough regulatory tools. Sometimes they had tools and they didn't use them. So with that prismatic view focused on who is minding the store, that led us to explore this. If the federal government had really been paying attention, what signs might have existed before the system collapsed that these hospitals were slipping downhill? And we found that important things that the federal government tracks among hospitals didn't show the problem. We first looked at the question of hospital finances. We took information from the Medicare cost reports that virtually every acute care hospital must report to CMS, and we also looked at some audited financial statements that we could get for the Steward Health System. We analyzed the average for Steward's hospitals and compared that with the national average for all hospitals. And all 4 metrics that we looked at tells the same story. Here is the story as it looks when considering the operating profit margin. As you can see, for most of the years we analyzed, the average operating margin of the individual Steward hospitals, which is the dark blue line, appears to be in better shape than the average for all U.S. hospitals. However, when you look at that lighter blue line, which is the system-wide audited financial statements, from the beginning, things didn't look nearly as good. We can talk about why that might have been, but the big picture is that for Steward's hospitals, these common public financial data didn't reveal that they were getting into trouble. We also looked at some measures of hospital quality. And again, we analyzed 4 different measures based on data that nearly every hospital reports each year to CMS through a program called Care Compare. Here is what one looks like. This was the measure that looked at serious medical complications for from all sources. And you can see that the average rate of complications for Steward's hospitals was consistently hovering right near the nationwide hospital average. So again, the main public data that the federal government collects about hospital quality didn't show what was going on. Now, these analyses got us thinking. Weren't there any clues that showed that these hospitals were getting into trouble? And it turns out that there were, but they're not things that the federal government usually tracks. One thing we looked at was lawsuits. In particular, we looked at lawsuits that were filed against one of the Steward hospitals or the parent company by its vendors, alleging that Steward was not paying its bills. These were things like contract staffing companies, air conditioning service companies, that kind of thing. We looked at almost 130 of these vendor lawsuits. Altogether, we found that they were seeking $139 million in allegedly unpaid bills. The number of these suits escalated, as you can see, as the system neared its collapse. They went from 9 in 2022 to nearly 60 in 2023, and 47 more the first months of 2024, just before May's bankruptcy filing that year. So you can see there is a pattern with things getting into trouble. We also got interested in something called hospital deficiencies. These are things that hospitals do wrong that lead to a complaint, that lead to a state investigation, that lead to a confirmation that a problem really exists. And again, you can see a clear pattern as the collapse of Steward approached. The federal government defines 3 deficiency levels depending on their severity, and the worst of the worst deficiencies are called immediate jeopardy. There are things like the case of Merle Hodge's death. And we found that, as you can see in this chart, deficiencies grew at every level shortly before the system collapsed. The records of immediate jeopardy deficiencies made for some really intense reading. At one hospital, Sharon Regional Medical Center in Western Pennsylvania, the records say that the facility lacked the proper supplies for 29 surgery cases, and for 2 patients, the records say, cardiac cases were attempted but unable to be completed. So there was visible evidence that these hospitals were having problems. It just didn't lie in some of the main public data that the federal government collects to track hospital finances and hospital quality. So what exactly was missing in action? Well, at the federal level, CMS, as I said, is an important agency. And the cost reports that we use to look at how Steward hospitals were doing, they're mainly used to set hospital rates. They're not used as a way to see how hospitals are performing financially. And CMS itself does not routinely check hospitals' quality. As one of our panelists who used to work at CMS said to me, and that's this quote, "There aren't enough warning signals built in before a crash happens." Now, at the state level, as I said, health agencies and attorney general could be doing a better job. One big issue is how much states get involved when hospitals and other healthcare facilities are changing owners. We'll hear a bit more about that on our second panel as well. And as you can see from this map, states vary a lot in how much they get involved. Not at all, only when it's a nonprofit hospital that's changing owners and wants to change owners, Or in just 15 states, those are the ones colored blue, a state looks at transactions involving both nonprofit and for-profit hospitals. But even in states that broadly require notification of a sale or an acquisition, most of the states lack the power to say no to that ownership change. They just have to be notified. As for penalizing hospitals when they do things wrong, CMS does not have authorization to levy penalties, financial penalties. So it's up to each state when a deficiency is found, whether it's going to have financial penalties and whether it's going to use them. In the case of Sharon Medical Center, where the surgery cases were started and stopped, Pennsylvania has financial penalties, but didn't ever fine Sharon, preferring to try to work with the hospital to make things better. So after looking at lots of data and at current regulatory practices, we have a few rudimentary thoughts about where to start looking to make the situation better. The first is to collect better data on both hospitals and health systems and hospital quality, and really use that data in closer to real time to do more rigorous oversight. The second is to raise the stakes for hospitals that provide substandard care. And that can be done in a lot of ways in these penalties that I'm talking about, or simply in working hard with the hospitals to try to make them do better things. The third is to change regulatory practices so that the sale of for-profit hospitals gets as much scrutiny all over the country as the acquisition of nonprofit hospitals. So such changes might prove useful in the future. For now, some of those policies that could better protect patients aren't in place. So to end, I'd like to circle back to Merle Hodges' case with a hint of how tough it can be even when a state is trying to pay attention when it is dealing with a recalcitrant healthcare company. I mentioned that the Louisiana Department of Health levied a fine of $1,750 for this woman's death. From that August, the state records show there's another letter in the file, and this is that letter. And what it basically says is that the check that Steward sent to pay the penalty had bounced. Thank you very much. I think we've got 2 minutes and 40 seconds for a couple of quick questions. And if you could just identify yourself and your affiliation. Yes, sir.
Retired. The hospitals spend an awful lot of money on QA activities. They have a whole superstructure. Trump would have a great time tearing it down. And they got a lot of employees, and they're checking. And what they use is the wrong metrics, and it's poorly done. So in the New England Journal of Medicine had articles on this stuff for the last several years. What is actually being done except verbalizing these high principles?
Well, we're going to hear from
Where does the rubber meet the road?
Well, we're going to hear from somebody who's had senior roles at CMS who can speak to that. But big picture, federal government is not doing a lot of real-time oversight of what's happening inside hospitals. It's a short answer, but that summarizes what's not going on. There one more question?
That was a terrific presentation.
Thank you.
I've been on the board of trustees for Ascension Health for a decade. Ascension Health, as you may know, is the largest nonprofit hospital system in the country. I had to smile when the senator spoke about rapacious greed. Our CEO has a base salary of $14 million a year. Right here in Washington, MedStar, nonprofit system, the CEO has a base salary of 7.5 million a year. These are not brilliant physicians. These are professional administrators that are basically running a public utility. And when you have a CEO with a base of 15 million a year, that means the numerous vice presidents are getting paid 5 million a year. Now, I've never seen scrutiny of the nonprofit system and what the senator described as rapacious greed. And finally, I had to smile when he spoke of an emergency room average waiting time of 3 hours. Down the street at Georgetown University Hospital, the average waiting time for the emergency room, the emergency department, is 5 hours and 15 minutes. So my other request would be to shed a spotlight also on what's happening in the nonprofit system.
Well, this project was not looking at the distinctions between for-profit, private equity backed, which is a subset of for-profit, and nonprofit hospitals, but there's certainly a wide research literature that has done that work, and it finds that some for-profit hospitals run well and some run badly, and some nonprofit hospitals run well and some run badly. So I don't dispute your point. I think we're out of time, and thank you all very much.
Well, thank you, Amy, for that. And it's good to see you all. My name is David Wessel. I'm director of the Hutchins Center on Fiscal and Monetary Policy. And I have the honor of moderating two panels today. I do want to, before we get started, I want to echo something that the last observation that the last gentleman made as he leaves the room. So there are about 5,100 acute care hospitals in the United States, not counting those that are operated by the federal government. 58% of them, as Amy said, are nonprofit. About 24% are for-profit, and 18% are owned by state and local governments. And the focus of the conversation today is on a subset of those for-profit hospitals. So there's 1,200 for-profit hospitals, and some fraction of those have private equity investment. And I do think it's important to remember that it's not the point here to say, despite what the senator said, that for-profit hospitals are inherently bad and nonprofit hospitals are inherently good. I think rather the point is that Steward Health tells us that our regulatory system has failed. And I believe that markets are often and can be the best way to organize economic activity, but they require adult supervision. And this is a case where the adult supervision failed, and the point here is to learn how do we repair our system so we don't have failures like this in the future. So we're lucky today to have Jessica Bartlett, who's remote. She's a medical reporter at the Boston Globe, covering hospitals, health insurance, and health policies. She's covered health policy for more than nearly a decade. Most recently, she's been with the Boston Globe since 2021, and the Boston Globe has done extraordinary good reporting on the Steward Health issue. To my right here is Michael Echols. Michael is a Republican member of the Louisiana House of Representatives, where he served since 2019, and he represents the district where Glenwood Hospital was, where, as Amy said, was a Steward Hospital that failed spectacularly. And that's a case where we'll learn a lot about real estate investment trusts that buy the land and building from a hospital, and then, which means a lot of money goes to the owner of the hospital, like Steward, and then they get rent, and that's a way for them to exploit the real estate without taking responsibility for what goes on there. And I should note that Representative Echols is not entirely hostile to healthcare. That he spent a decade working for Vantage Health, which is a small health insurance company based in Monroe, Louisiana, in his district. So I think, Jessica, I'm glad you're with us. I'm sorry you can't be with us, but your living room or your dining room looks great.
Welcome to my kitchen.
Yeah. I wasn't sure if that was a real backdrop or a fake one. So I wonder if you could just walk us through a little bit how you got interested in this. What was the journalistic process? How did this unfold? Because we know a lot in retrospect, but I want you to take us back to the beginning.
Yeah, so I started my journalism career in 2010, covering many towns in the South Shore of Massachusetts, including Quincy. And Quincy had a hospital called Quincy Medical Center. And so one of the first stories that I was covering as this, newly graduated journalist at the time was a for-profit switch of a long-time nonprofit hospital. Steward Health Care had just been created, and they wanted to acquire Quincy Medical Center. They had been created, as Amy mentioned in her previous presentation, out of the Christian Caritas system, and they were trying to expand it and add more hospitals to it. And so I have really watched Steward grow throughout my entire journalism career. And, at the time, Steward was doing things in a different way. They were kind of a move fast, break things mentality. They wanted to leverage the Affordable Care Act, care for low income populations on a budget. They were bullish about the prospects of being able to make money doing this. And so that kind of set the stage for a lot of what happened. People, I think, made excuses for some of the things that were going on because they were doing things a different way. But there were some signs of distress, I guess, through the years. So to begin, my initial coverage of Quincy, there was a nurses' strike at Quincy Medical Center. At the time, nurses' strikes were very rare in Massachusetts, and so it was a big deal. And there was tremendous pushback from Steward at the time. It was kind of the first glimpse I received of how the management chain kind of acted when questioned. And I remember that I kind of learned this in retrospect, but Ralph, I guess, would like to have his press people call journalists to yell at them, and he would sit in the background of the call on speaker while they did it. And so I got this phone call one day just from covering the nurses' strike, threatening to make me lose my job. And so it was a really aggressive pushback to any kind of coverage that they would get. They also, they went on to do some really interesting and different things that Massachusetts had never seen before. In 2016, it sold its real estate to a real estate investment trust. No one had really seen that in Massachusetts. No one knew what to make of it. But again, Steward had a reputation of doing things differently. They had partnered with a private equity firm, which was kind of unheard of at the time in 2010, which received the blessing of the Attorney General at the time too. And they promised to reinvest the proceeds when they sold their real estate into the hospital. So it seemed like this really innovative way of maybe this is how you care
Let me just stop you for a minute. So,
populations.
Well, a little bit longer on, you said received the blessing of the Attorney General. So what's the process in Massachusetts?
Yeah, in 2010, when Steward was trying to transition many of these hospitals from nonprofit to for-profit, although the state really lacked, up until recently, the ability to oversee for-profit systems, this was kind of the one way that the state did have a mechanism to kind of enact its power, to put some kind of controls on how nonprofit systems transition to for-profit. And it was a lengthy process. And reading back through some of these reports, people said the exact same things that ultimately ended up happening. They said private equity is going to come in. It's going to take millions of dollars out of the system. It's not going to be beneficial for patients. The Attorney General, I remember, so it was Martha Coakley at the time, and she said in this report, we acknowledge those concerns, but they've never materialized before with the hospital. And so we don't think they're going to happen here. Some of the controls that typically happen, like putting the assets of the nonprofit into a trust for the benefit of the community, didn't happen here because the deal was so tenuous with Caritas. The system was so fragile. They were concerned that if they put more conditions on the project, that the private equity firm would just walk away entirely. And this has kind of been the question that has plagued, I think, the Steward system throughout its entire lifespan. Is no hospital in a community better than a bad hospital in a community? And at the time, Massachusetts wanted to preserve all these hospitals, all these jobs, and ultimately gave it the check to move forward.
So, what has happened in Massachusetts on the legislative and regulatory front since this thing blew up?
So, Massachusetts has passed what was at the time one of the furthest restrictions on private equity. We have done in Massachusetts, which I think Senator Markey has proposed doing on the federal side, which is to restrict hospitals from selling its real estate to real estate investment trusts. We've also put a lot of monitoring on private equity involvement when it comes to ownership of hospitals. Some say that this still doesn't go far enough. It's not restricting private equity involvement in hospitals. Private equity still has a lot of tools to leverage and make money off of these deals. But at the very least, we have some transparency into what's happening, into what the ownership is, and more mechanisms to file ownership and financial information with the state.
And what's happened to Quincy Hospital?
So Quincy Hospital is kind of a bellwether of how things would all unfold. When Steward purchased it in 2012, they promised they would keep it open for several years. It was one of the conditions of them purchasing the hospital. Lo and behold, they did not. They closed the hospital in 2014, even defying the state's notice of how long they're supposed to give a heads up about how quickly they were going to close a hospital. And the state didn't do really anything about that. They let it proceed. They said, okay, you need to keep an emergency room in the hospital for a series of years, and Steward did, I think, up until 2020. But there is no more hospital in Quincy, and they sold the real estate. And so that was a sign of things that were to come down the line.
And just one more question. So, given that, forgive me for this, the original sin here was that of the Catholic Church, which had to sell all these hospitals because it had to pay off lawsuits involving the child abuse scandals. Has the church been involved at all subsequently in trying to repair the problem that they helped create?
No, the church's involvement to date has been to make sure they receive their religious artifacts back when these hospitals transition to new owners that are not religiously affiliated.
Interesting. Okay, Representative Eccles. So take us to Louisiana. And first, because Washington is a very provincial city, tell us a little bit about your district in Louisiana. I gather the big town there is Monroe. It's in northeastern Louisiana. But just tell us a little bit about it for all of us who, don't know anything that happens south of the Beltway here.
Sure. So one, thanks for having me. But two, Northeast Louisiana is a very rural part of Louisiana. Monroe, West Monroe are kind of brother and sister cities along the Ouachita River. Beautiful environment. It is the regional epicenter, though, for healthcare. Where Glenwood is, and we have two other regional hospitals, is where everyone comes for a 13 to 15 parish or county area for their healthcare. So it is the centralized spot for commerce, for economics, and then for our healthcare delivery system, which was mangled by Steward and their proxies.
So tell us a little bit how you first got involved in this.
So a couple of years ago, I was getting phone calls from doctors and nurses at Glenwood that were saying their lack of supplies, other issues within their system. Soon after that, their labor and delivery closed, which, you shut down a labor and delivery center, you cut off a vital healthcare asset. Soon after that, again, more phone calls, patient care issues. So I ended up calling a hearing of our Health and Welfare Committee, which I sit on, and we had their CEO at the time, John Turton, and some of their folks come to the Capitol to talk about all these issues that have transpired. We had other regional hospital CEOs come so they could talk about their impact because they're having to pick up the water while this hospital was continuing to cut services and hurt patients. During an interaction with their CEO, he admitted on the record that they killed or maimed patients. And when you say that in public, that to me is a very serious charge. And, we had seen it just because of the patient complaints and the doctors and others that were working at the hospital, not to mention, the countless lawsuits. The goldfish in the hospital were repossessed. The coffee machines were repossessed. There were allegations of HIPAA-related violations with documents being transported out in open areas, elevators that were down in the facility. So this was a horrible situation that, admitted on the record, they had committed that malfeasance. So my next job was to figure out ways from a legislative perspective to help prevent that going forward. Now, unlike many others, I'm sure, whether it's in the room or on the panel or in the legislator that spoke earlier, I'm not against private equity in healthcare or any other facet of the economy. What I am against is when they have no accountability measure and then they can funnel money back and forth between the operating company, which they leased for exorbitant prices, and have no regulatory oversight of those lease arrangements. Hospitals are there for the public good, and I'm okay with a hospital being a for-profit hospital, but you have to have those that enable what, in I think the case of Steward, is a big fraud. Those that enable that fraud and probably participate in it in some form or fashion based on the financing schemes that happen after the fact, they have to have accountability too.
So how did Steward first get involved in Glenwood? Was it a nonprofit hospital that they bought, or was it?
It was a local hospital that they acquired. IASIS actually owned the hospital, which they acquired from the parish, which owned it for $80 million, some probably 20 years ago. Steward came in and either acquired or took over the operations from IASIS. They ran the hospital for several years, somewhat quietly. You did see the quality metrics that Amy presented and some of the other things, and we heard about those. They were trying to be novel in the healthcare delivery space. And up until you get into the COVID crisis, I think they were in trouble then. But because CMS and the feds injected just hundreds of billions of dollars into the healthcare delivery system at the time, it probably masked the problem earlier sooner than it should have actually happened if the regular healthcare market was happening. So it had been going on for some time.
And before all this, what was the regulatory situation in Louisiana? How much oversight did they have over purchases of hospitals or measuring and maintaining quality?
Well, Amy mentioned about the for-profit hospitals have less regulatory burden than a nonprofit hospital. That is something I think needs to change in Louisiana and every other state. You still want for-profit entities to have the ability to do commerce. But when it has to do with a public good issue like healthcare, I do think that state and federal regulators do have some level of oversight. And then I agree too, we're not monitoring the right data sets across the healthcare delivery system. We're still antiquated by what CMS does and what our state regulators do because they're checking boxes that have been in place for decades. I think when you're looking at the financial health, those regulators need the ability, if you have a sale leaseback with like a medical properties trust and a Steward or now American Health Systems, they need to have at least a reasonable oversight to say that contract will never be fulfilled. You don't produce enough revenue in your hospital to even pay your lease amounts, which then goes back to the private equity markets. How they don't ask for more regulatory oversight. I think there's a Securities and Exchange Commission conversation here too, to look and analyze these deals to make sure they're not just fake paper.
So what's happened in the regulatory or legislative space in Louisiana since all this blew up?
So I ran a bill last year that, of course, it flew through the House, but it would have required, in my case, medical...
Of course, it flew through the House because you're such an effective legislator.
I'm in the House. Well, the Senate throws a different, roadblock in some cases. But, I had a bill that would have essentially held the holder of the asset, in my case, Medical Properties Trust, the publicly traded REIT that has colluded and worked with Steward and now American Health Systems and others. It would have required and held their board of directors, those that are responsible for running their company, and their CEO financially responsible if they would have allowed that company, for some reason, to, one, negotiate bad deals that propped up their, stock, and in exchange, they've got a piece of paper that says they get an absorbent amount of rent. But if that company that they lease to, the operator, Medical Properties Trust, to Steward, the operator, it would require them to have real direct oversight of those contracts. And if they fail within 3 to 4 years, they're held financially responsible.
And what besides your bill, has anything happened in the regulatory or legislative front since all this?
You know, I testified before the Senate Help Committee, and we talked about steward, which is great, but I think it's more about Medical Properties Trust. They're the ones that are facilitating these frauds by doing these baked contracts with these operators. So I think if we're ever going to have, true oversight of these issues, the REIT itself, you have to look at it and hold it responsible in a way that has a financial impact either on their directors or their shareholders that is visible by the public.
Right, but given that this thing blew up in your district, has anything yet changed in regulatory or legislative environment in Louisiana?
Not yet. My bill failed in the Senate. Medical Properties Trust flew their CEO in. They hired several high-powered lobbyists. They basically picked off senators, and the bill got killed 1-4, or it would have moved forward. Now, I am working with my Attorney General and others. There's more than one way to skin a cat, and we will find additional ways that we can provide oversight, either through new hospital acquisition or transfer, and that may be from a criminal perspective versus the for-profit regulatory perspective. But I think there's 3 or 4 different bills, maybe more, that we'll work on to try to find some level of oversight to stop the Medical Properties Trust from working with shady operators.
All right, so just so I understand, so Glenwood Hospital is still open, yes?
Yes.
And it's now operated by
American Health Systems.
And American Health Systems is a for-profit chain?
Well, it is.
Yeah.
Their new president is the former, I think, legal counsel for Steward Health Care, Josh Putty. So you guys be the judge of this. But when you look at, you're just shuffling.
Now we're into the
when
HBO
you're just shuffling
script.
executives from one hostile actor to the other, and then the mothership, which is Medical Properties Trust, continues to fund operating dollars back and forth, which real estate investment trust legally cannot do that. They're not supposed to funnel operating money back to the company that they're leasing to. That's why it just blows me away the Securities and Exchange Commission has not gotten involved.
All right, so let me understand this. So Steward goes bankrupt.
Mm-hmm.
And so basically Glenwood is one of their assets, the right to operate a hospital, and that is sold to this other chain.
The bankruptcy judge, who the CEO of Medical Properties Trust came and said, well, the bankruptcy judge forced this new operator on us. They didn't even consider other operators. So he's even said some what I could consider untruths on the record as well. But they're just shuffling execs around between these lower level operators.
And what do you hear about the quality of care at Glenwood? Anything good or bad?
So we have the same operating issues. We have the same types of lawsuits that are being filed by vendors that aren't being paid. We have the same elevators that aren't operating in the hospital. I got a call 2 weeks ago that one of the the only elevator that was working wouldn't go to the top 2 floors anymore. So we had patients that were stranded there for many, many hours. So we're not in a better operating environment. It's the same song, different set of bad actors.
Well, that's encouraging. So, Jessica, I wonder if you could talk a little bit about, so I'm a former journalist, so you guys are going to have to indulge me. That's the advantage of being the moderator. How did this all unfold within the Boston Globe? And how did it go from, so you were covering this, I forget who you were working for before you were at the Globe. Who were you working for?
Well, I was at the Globe in 2010 to 2014, the Boston Business Journal, and then back to the Globe.
All right. So you go back to the Globe. It's 2021. This thing hasn't quite exploded yet, but it's in the headlines, right?
Well, COVID dominated the healthcare landscape from 2020, 2021, 2022. And all of the kind of problems that you would hear at hospitals were kind of chalked up to, well, we're living in a COVID environment now. It wasn't until the fall of 2023 that I started hearing from numerous different vendors we're not being paid. And, it made me take another look at Steward in a more aggressive way that I had not done for some time because they were not filing financial information with the state, because they were so private about how they operated. So there wasn't a lot of public data on how they were doing. They weren't kind of meeting those thresholds like the rest of the healthcare system. But as Amy pointed out, you could see it through the lawsuits. And so I started looking up a number of lawsuits. And as I talked to different people, I came to understand that that not only were they not paying bills, but they didn't have supplies as a result, that doctors were seeking privileges at other hospitals, and that a woman had died. And so I was able to find...
This was the C-section story? Is that the one who died?
This is Sangeeta Rashid. She gave birth and started to bleed. The hospital did not have an embolism coil to stop the bleeding because it had been repossessed by the vendor for non-payment several days prior. She was transferred to another hospital, but ultimately died. And in discovering all of this, I'd also discovered that Steward was threatening the state to close services or hospitals unless the state gave them some kind of bailout. And so in January 2024, I published two stories. The first being that there was a healthcare crisis happening in the state. Steward operated several hospitals. They were one of the biggest health systems in the state, threatening to close services and hospitals and facing financial calamity. And then the second story was about not only was there financial problems imperiling the state's healthcare, but individuals' healthcare as well.
And had this been an issue like at the legislature or among politicians before your stories came out, or did you start the whole bonfire?
They were trying very hard to have these conversations behind closed doors. There was a concern that they didn't want to freak people out, that if you tell people that the hospitals are in free fall, that they will stop going to them, and then that will kind of hasten the decline of some of these facilities, which I appreciate. But also, people should be empowered to know what is happening with their institutions and make decisions for themselves. Yeah. And people were dying as a result.
And how much was this a one-person reporting thing, and when did Spotlight got involved at some time, the investigative team? What point did that happen?
So after those two stories, they kind of blew up our website, and then people started to panic about what was happening, why no one had caught this. And so the Spotlight team convened the largest group since the Catholic Church abuse scandal to focus on Steward and dig more into what were the scale of the deaths and the problems. Our collective reporting unveiled at least 15 deaths that resulted from a failure to provide standard health care, and thousands more put at risk. And even today, we have 2 hospitals that have closed in Massachusetts as a result of this crisis. The state has spent and will spend over several years $700 million, and we'll only get a portion of that back from the federal government. Steward is still in bankruptcy and trying to claw back money from Ralph De La Torre and several other executives. And because it also raided its medical malpractice insurer that it had operated out of Panama, there are doctors who no longer have medical malpractice insurance for lawsuits that they are facing for care they delivered back in the day, and claims that have been settled that have not been paid out. So the scale of devastation continues to ripple.
And what has been a number of the Martha Coakley and the current governor, where do they accept some responsibility for letting this go on, or are they blaming it on somebody else?
No, they feel that they have done yeoman's work to address this. And I mean, to their credit, they did bring majority of the Steward hospitals in Massachusetts into nonprofit ownership, and are still being operated by those nonprofit owners today. So the scale of the crisis could have been far worse. But as far as accountability for the lack of action over years, not filing the fines that they could have fined Steward for not putting in their financial information, not holding them to numerous state regulations, not watching closely enough when they were doing these kinds of deals. No, they have not taken accountability for that.
So, Representative, how many, were there other Steward hospitals in Louisiana?
So there's no Steward hospitals in Louisiana but Glenwood. Now, Medical Properties Trust does own other assets, like with Ochsner in South Louisiana. So, they're still involved there, I guess, indirectly.
And where's the political establishment in Louisiana on this, or the Louisiana press? Has this been an issue, or are you like a lonely...
I some days feel like I'm on an island.
Yeah.
But the Boston Globe has been terrific. Mother Jones has been terrific. I get all the Wall Street Journal's been terrific to follow this story because it has national implications. It's just we don't have a vibrant media corridor in North Louisiana. It's more South Louisiana with the Advocate and the
Right.
Times Pick and those types of publications.
What about like the governor and people like that?
So he is very aware of the situation. The Attorney General is too. Because it's a for-profit hospital, it makes it a little harder. You know, in this scenario, I want to get the asset out of the hands of the corrupt people and just put it in the hands of somebody that's going to take care of the asset and the people in the community. What legal remedies we have, you know, we're still exploring all those right now. And so we want to follow the legal processes to the T so they don't keep us in courts for decades to come.
And as I understand your argument, Stewart is, I don't think we have to condition that, a bad actor here, but you think the whole business of real estate investment trusts, buying the land and the building of the hospital, and then making a priority collecting their rent rather than what's going on in the building that they own is sort of one big cause of the problem. Is that fair?
I think if you have a REIT that doesn't operate both fairly or what I would even deem legally, them working with an operator is not a good scenario. I think that the process of bringing capital to markets, so you as an operator of a hospital or a hamburger joint, that's fine.
I see.
But when it's deemed worthy of public health, I think the REIT should have some financial responsibility too directly if they intentionally are doing artificially inflated rents to absorb profits out of a hospital. Their boards of directors should have financial penalties as well.
Right. Okay. I got lots of questions, but I'm sure you have some too. Here's what I'd like to do. First, wait for the mic. Can you come down here, Sam? Gentleman here. Tell us who you are, and I'm going to take 2 or 3 questions, and then we'll see who wants to respond to which ones. Right there. Raise your hand so he knows who you are. Yeah. So
I couldn't tell if there's someone behind me there. No. Hi, my name is Todd Brazil. I'm a retired Army officer and former political appointee. So two parts. First, Representative, I know that these hospitals are taking capitated payments from the VA, from HHS, from states, from TRICARE through the military for their swath of patients. And there seems to be a lack of interest in driving any sort of regulatory policy on those funds. You can have a ton of money dedicated towards a fairly healthy group of people that makes your profits higher. But when you have people who are sicker or older, obviously that becomes a more expensive deal. So it's obvious where money can be scooted around and moved into people's pockets, or in Ralph's case, 2 yachts. So I'm just curious if there is what y'all have done to sort of press the federal government to exercise its rights for figuring out where their money's going and how it's being spent. And then Ms. Bartlett, I'm curious what's become of sort of the hospital networks that were left in the wake of this. The nonprofit Brighton Marine, for instance, is thriving. It's an actual nonprofit, not just sort of one that takes care of its board. So I'm curious, like, where the follow-up is with those folks and sort of what you're looking at next. Thank you.
Thanks. There's a woman in the back by the camera.
Hi, thank you so much for the presentations. I thought it was like really interesting. So
Tell us who you are.
my name is Pinky. I'm a UC Riverside student. I major in political science and economic. And when I listen to your presentations, I kind of wondering why of all these systems are, oh wait, no, sorry. Why of all these U.S. hospital systems are not opening new ones? Instead of, I feel like, these old hospitals are being circulated through vendors and nonprofit instead of like opening new ones that, I think might have like a better chance of surviving than, circulating old infrastructures and broken administration system through like the healthcare system of America. I know it could be wrong, but that's just like my interpretation so far.
I'm going to make you answer that one, Richard. I hope you were listening. You want wait for the mic. Sam down here in the front.
Thanks a lot. Hi, everybody. My name is Sebastian Marin, and I'm coming far away from Romania, actually, for this event. I'm representing and here behalf on the National Rehabilitation Institute, Physical Medicine and Balneoclimatology from Bucharest, Romania. We're basically a state hospital with a lot of centers across Romania, around 6, and we're still trying to open as many as possible because we need to serve the citizens. We are a state hospital, so it's a different subject. But we heard about the Steward collapse, even in Romania. How so? I don't know, but yeah, it was quite interesting to see that.
It's the Boston Globe has a far international.
Yeah, truly. And it's pretty strange, actually. We're trying to learn from you guys, but I see you're dealing with some problems at home too. And I'm having a question for the honorable representative of Louisiana. And what do you think is the first step in order to deal with this kind of problem? Because you just said before you had a bill, but somehow that's how politics works, I guess. They got paid off and they killed the bill in the Senate. So do you think the federal government should get more involved into this problem? And what do you think is the solution? Because in my opinion, I think it's all about the mentality. And in order to change and do a real change, we have to change the people's mentality regarding healthcare.
Great.
Thank you so much.
Thank you. Jennifer, why don't we start with you? So what has happened to the network of hospitals, the nonprofits, in the wake of this in Massachusetts? And how are they being absorbed into the big nonprofit consortiums that dominate healthcare in Eastern Massachusetts?
So 3 nonprofit systems acquired several a piece of the Steward system. They are still functioning today. They have new names, they have new owners. The religious artifacts have been, like the crosses have been removed from the walls. But this is not to say that they are doing great. The state has provided millions of dollars just in this last month to a number of hospitals to help prop them up. I mean, this is not necessarily because of Steward alone. Hospitals are struggling right now for a variety of different reasons, from Medicaid cuts to NIH challenges. And so this is kind of part and parcel of everything. But these hospitals will take a tremendous amount of reinvestment and have already necessitated a tremendous amount of reinvestment from the state and from these individual institutions to help support them. But whether they survive over the long term, I don't know.
And Representative, so do you think the federal government has a role here if the states can't handle this?
So they do. I think from a regulation standpoint, they ought to have rules and regulations from publicly traded REITs that they follow more stringent protocols so they can't do what's happening here. In my opinion, it's an absorbent lease that's being done by a publicly traded company to companies that have no long-term plan to pay those absorbent leases because they can't. They're not financially sustainable. And to the gentleman's question over here, the other component I think that the government has a piece in, if it's a risk-adjusted line of business like a Medicare Advantage plan or someone that's paying a capitated rate, they still have the ability to look at risk pools and understand the cost of care and the quality of care from those lines of business. The reason why a Steward or someone that has those risk-adjusted payments doesn't work long-term is eventually the data catches up with you. Eventually you can see that pool of patients is sicker and getting worse care. And so I think there's a longer term conversation about how do you go to more risk adjusted payment methodologies that may have capitation payments or whatever other payments that are out there. And this is getting into the weeds, but I think over longer periods of time and larger pools of risk or population, you can manage this, but you have to stay on the data on a quarterly or annual basis. If not, you get a bad actor that comes in there and loots the system.
Richard,
And if I could just add too,
please.
I mean, in terms of like the immediate jeopardy process, this isn't necessarily capitated risk, but in terms of the federal government using the funds it has to kind of force actors to do certain things, that's what the immediate jeopardy process is. If a hospital does not fix their immediate jeopardy, CMS can pull their Medicare payments, and a, a that is a hammer rather than a scalpel to dealing with the problem. It basically shuts down a hospital. So, I mean, I think the next panel will get into this,
Yeah,
but
exactly.
part of the problem is that as a federal government, the only tool they have is to shut down a hospital entirely, which is often just not something that people are willing to do, even when the stakes are quite high.
Ross, can you give Richard the thing? Richard, I was going to attempt to answer a question that you know more about than I do. So, do we have too many hospitals in the United States? Do we need more hospitals? Well, she asked, why are we trying to save these old ones? Why don't we just build one? So, what's the...
Well, I don't necessarily think it's a matter of too much or little, and Massachusetts is a good example. You could interpret the Massachusetts thing as they were buying time to keep the hospital stock in place. And that's how they originally cut the deal with Del Torre. And I think that's true in other parts of the country, that you have all this infrastructure, you have employment, you have doctors that are tied into the community. And so I think there's a natural inclination to try to build those up and preserve them. And especially when there are promises being made about innovation and change, it's a natural thing. The answer to your opening question is it depends where you are. Right. In Massachusetts, they were worrying that particularly like in the relatively transitional low-income areas like Dorchester and things, there's a real risk of older and adults and disabled adults to really have nowhere to go who are low income. And that would have been a hugely disruptive circumstance in Boston. And so I think,
so basically the instinct here is we need to get some money into these hospitals to keep them alive, at least for the near term. And we went to where the money was, and that's how you end up with people like MPT. Great. We're going to, all right, Wendell, it's got to be a quick one. You're interfering with the coffee break now.
Wendell Primus, Brookings. Representative, have you talked to the Louisiana delegation, particularly your senators, and are they sympathetic to the issues you raised?
Yes. So I've worked at the federal level with Senator Cassidy, and I've testified before their committee before. And then, of course, our congressional delegation, Representative Letlow. And of course, we've got Speaker Johnson. He's vibrantly aware of the issues in his team, and then even the majority leader. So, yes, we have had communications with them. At the state level, my entire legislature knows about it because of the hearings, and I do tend to make a little noise when I'm trying to advocate for an issue, especially as important as our healthcare delivery system. And I just wanted to say one thing to
Please.
Another point that you guys have brought up around, I guess, some of the challenges with, from a regulatory standpoint in looking at this. You've got actors that are functioning that have been trained at these major Ivy League schools that understand high finance. The intersection between high finance, though, and healthcare is far more complicated than just buying a bunch of buildings and leasing them out. I think they're predatory tactics now for systems like a REIT, a medical properties trust, or others to go and buy up as many healthcare assets they can in a state and then bankrupt them and then go to the legislature and try to say, you either do this or we're shutting them all down. That is a corrupt practice, and there should be protections in place where you cannot consume all the healthcare assets and then run them out of bounds and then try to go to the state legislature, the federal government, say, give me more money or else. There should be responsibility for those people that run those facilities or that own those facilities that they can't do that. And if they do something like that, there is a massive penalty on them personally.
Okay, so with that, we're going to take a 10-minute break. There's coffee outside. We'll come back at 2 minutes after 2. 10 minutes, right? Great. Thank you, Jennifer, and thank you. Dan, is the mic? Yes, it is. Hi. So welcome back. And if you missed the first act of the play, I'm David Wessel, Director of the Hutchins Center on Fiscal and Monetary Policy here at Brookings. And in this panel, we're going to move from the ground level, Boston and Northeast Louisiana, to the regulatory front. And we have a great panel here. Jonathan Blum, who's now a non-resident senior scholar at the USC Schaefer Institute, had back and forth at the Center for Medicare and Medicaid Services, most recently as the deputy administrator, and Maureen is senior program director at the National Academy for State Health Policy, which is a nonprofit that focuses on states' efforts to finance, provide, and improve coverage and care. And Erin Foos Brown is a professor of health services, policy, and practice at Brown, and she was previously at the law professor at Georgia State University. So maybe I can start with you, Maureen. Can you talk a little bit about what is the deal at the state level? What is it that we should know about the way that states regulate for-profit, and nonprofit hospitals that's relevant to the subject of today's conversation?
Sure. So I'll start by saying unlike insurance, which was explained earlier and has been in a for-profit space perhaps longer than have hospitals, there isn't a natural place within state government to regulate the finances of hospitals. States regulate and oversee, I know to a degree, quality, but also safety standards. They license hospitals, but there's no natural place unless you create one where states are regulating or overseeing finances, transactions across entities. A lot of folks will raise antitrust, and obviously antitrust regulations at the state level exist, but often these kinds of transactions fall below an antitrust trigger. They happen typically over like a series like Steward. It wasn't all at once that they were in 10 states with 30 plus hospitals. It happens slowly. And states just don't have the tools unless they create the tools. And until very recently, it hasn't been as much of an issue. The financialization of healthcare and of hospitals in particular has been a more recent phenomenon that has been presented to states. And NASHB does have some model legislation that states requested we create for them. But as you heard, that can be a challenge to get across legislatures for a lot of different reasons. But foremost, it really is this issue of balancing access with oversight. And since there's not a natural place in state government for oversight, it would have to be created. And so there's a lot that has to happen in order for that to move.
So one of the things that's come up occasionally is that in many states, the state is different standards and different processes for approving acquisitions and mergers of nonprofits versus profit hospitals. So I'm going to ask you this question too, but is that just because the policy hasn't caught up with reality? Is that basically the issue?
I think so. I mean, the other issue, and again, I haven't looked at this or studied this very specifically, but I know there are states who have attorney generals that have responsibility over nonprofits, period. And it's not necessarily nonprofit hospitals. So they have a responsibility to ensure that nonprofits are fulfilling their community good and things like that. But it hasn't, and there's obviously a hesitancy to do oversight over for-profit entities in a lot of states for a lot of different reasons. But the nonprofit piece typically is for a broader range, not just for hospitals.
Let's see. So, Erin, first, why don't you take that one first, but I wonder if you'd step back and tell us, when you listen to the congressman and the reporter from Boston Globe, do you have some sense that they've diagnosed a problem, and how would you explain what the problem is?
Yeah, so I think that the conversation from the first panel really does, I think, crystallize really a problem that we are waking up to that has been a slow rolling development, as Maureen mentioned. And that is really this idea that these healthcare systems and hospitals in particular, but also nursing homes and other types of facilities that provide critical services to communities, we think of them as being these public goods or these social goods that require a certain amount of oversight and management to make sure that they remain accessible, that they are financially sustainable, that they sort of are there and able to care for the community. The problem is when the sort of the market forces come in and sort of in the effort of financialization, whether that's through real estate investment trusts, private equity, or other types of investors, see them as assets really to be monetized, and the money leaves the community. It leaves from the public. It's like these are public dollars, Medicare, Medicaid dollars in a lot of senses, or it's our own premium tax dollars. Premium dollars that we spend for our own health benefits. So this is all of this revenue, they see it as revenue that can be then extracted for the benefit of the investors. And so I think that is a diagnosable problem. Now, the question of like whether or not this is there was a little bit of a debate in the first session of like, is this really a nonprofit for-profit distinction, or is it more about consolidation and the effort to, and I think it's probably more the latter. It's the idea that health systems or the healthcare industry as a whole has become wildly more consolidated. And as a result of that consolidation, there's a lot more of this sort of profiteering opportunity, whether you're a nonprofit or a for-profit. And so some of the guardrails, I think your question is sort of prescient in the sense that the guardrails that maybe were built for a nonprofit hospital system being converted to for-profit really doesn't make sense and misses a lot of the healthcare system today. So I think the states that are sort of moving forward and sort of responding to this are the ones that are trying to put in place similar levels of oversight, whether it's a nonprofit health system or a for-profit one, but also, physician practices, outpatient clinics, outpatient, behavioral health clinics. Those types of entities are all being targeted for financialization.
So, so I take your point that some of these big, and the point was made earlier by the questioner, some of these big for-profit chains are really not, it's hard to distinguish them. Mm-hmm. Some of the nonprofit chains, the notion that the hospital is run by the elites of the town and they just have the public interest at heart, and that seems to be quaint. But what are the elements that you think we need to do on the regulatory front, either at the state or the federal level, that would prevent the kind of tragedies that we heard at Steward?
I think there are a few elements. I worked with NASHB to develop a sort of comprehensive model legislation for states to start to address some of these problems. And the first piece of that is to engage in much broader and more robust transaction oversight, and to define the types of transactions that receive prior notice, review, and also the ability to block or place conditions on those transactions, go beyond just hospital mergers or acquisitions, but also include real estate investment trust, lease sale, leasebacks, proposed closures of key facilities or key service departments that are essential to the community, and management service organizations buying up physician practices as well. That's a common way that private equity and in other types of for-profit actors are now entering the physician practice space. So I think that's one aspect, is transaction oversight. The second piece of that is really, I think the other part of this is this idea of transparency, but not just transparency over prices. We often talk about transparency as being sort of like put sunshine on something, and that in and of itself will solve the problem. I think here it's more just as a first step. And what do I mean by transparency? Transparency of ownership and transparency of financials. So the idea that we can have some reporting not only of who is the ultimate owner, when is who is in control of the assets? Is it, can we identify all the entities the facilities that are operated by a real estate investment trust in the state, in the country? Right now, it's hard to do. And so being able to identify those and being able to track it is important. But it's not enough just to know who's the owner. It also is important to get those balance sheets, those financial statements, have them be audited, be robust, be able to track the money when it leaves the system, in order to be able to put some guardrails around it completely leaving the community and being lining the pockets of the investor.
So, John, I do want to ask you about federal regulation, but first I wonder if you could talk a little bit about why is private equity moving into hospitals? Obviously, they see a way to make a profit, but why is there a supply of hospitals that are looking for this private capital?
I think there's two reasons. One is that I think we all want hospitals to do more things, to have better records, to have them be online, to submit quality data. And I think all the good things that we think about in the healthcare system to push more accountability that causes the need for more capital. And you could argue that private equity can bring new capital to those facilities that don't have the resources to submit quality information, to take more accountability for healthcare. I think one of the reasons that we have more private equity is that policymakers want the health system just to do more things that requires more investment. The second reason, I think, is there is a push by policymakers, whether right or wrong, to have healthcare hospitals, physician practices take on more financial risk. And that can do good things. That can really create stronger financial incentives to better manage care, to promote prevention. But I think when we take away the kind of fee-for-service system that brings us more transparency, that brings us more accountable definitions, that can have some concerns. But as policymakers think about pushing more risk, that creates more opportunities for private capital to help manage that risk. I think it's two reasons. Number one, that we want the system to do more things. And number two, that some believe that by delegating more financial risk to hospitals, that creates more opportunities for financial capital to move in, that will get better healthcare outcomes.
So just to pick up, I think I understand what you're saying. So we want to spend less on healthcare and get more for our money. And the theory was, if it's all fee for service, the more procedures they do, the more money they make. That seems crazy. So we moved to a system, we talked a little bit about capitation before, we want to give the healthcare providers some incentive to only do the necessary care and to be efficient. And you're pointing out that that means that we're asking them to take risk, and your average, 12-member board of directors of some nonprofit hospital isn't as well equipped to that as people who are in the risk-taking business, like private equity.
Precisely.
All right. So tell us about, how does the world look from your experience at the Centers for Medicare and Medicaid Services from the federal government? What do you think, there was this sense somehow that CMS was looking at the wrong stuff and not moving quickly enough, et cetera. I'm sure you've heard all this before. So how should we think about this?
I think two things. Number one is that by law, by process, every facility gets surveyed once every 3 years. That's work the federal government pays states to do, or pays separate entities to do for the federal government. So every facility in our country, hospital, nursing home, gets a survey. But then the government brings in resources when we hear patient complaints. Something bad has happened. I think those two processes create huge gaps to our oversight and to our overall promise to be good stewards to the healthcare system. Do we have a system in our country that requires nurses to go on staff to monitor supplies, to monitor the overall processes of care, but it's not nimble enough for us to catch things that happen between those surveys, or that we get complaints, and by that time it's far too late. for us to act.
And what about this immediate jeopardy thing? What's that? How to explain to us how that works?
So when a nurse team goes to a facility, they look at the processes of care, to look at the certifications for those providing care, and they often find deficiencies, and those deficiencies get fixed, or they're even determined to be so severe that they harm the overall care for patients. Those deficiencies get found, then the government, the federal government and states, need to decide what action to take. The strongest action you can take is to close a facility down, or to cut off Medicare financing. But those are really tough decisions to make.
Do they ever force them?
Oh yes. Nursing homes far more often. Hospitals get a chance to cure, but those do get cured.
Right, but I mean, as someone pointed out, the question is some hospital better than no hospital, and that's
Correct.
always what you have to do.
And you get pressure from the state legislature. You get pressure from local interests. You hear excuses why the system, had something go wrong. But those are tools the government has, but they're used very carefully.
And what's your reflection on Steward with the benefit of hindsight? Was there things that CMS might have done differently?
I think to our data, looking at when facilities have challenge, there is a high correlation when you have change of ownership. That could be nonprofit to nonprofit, that could be nonprofit to for-profit. But if you go back in data to look at which facilities had some severe challenge, there is a very high correlation between those events and the change of ownership. So I believe that the government, both federal and state governments, can do a far better job at dedicating resources, dedicating when facilities do get surveyed, not due to the calendar, but due to certain sentinel events like change of ownership. I think one change that we have to make in our country is to dedicate those survey resources. That you have to go on site, you have to see the processes of care, you have to see the supply cabinets, you have to see the drug distribution systems, but to really think about the time we do those surveys, not due to calendar, but due to when we see certain events like change of ownership.
Interesting. I mean, I've been struck in reflecting in this whole conversation how different our system of bank regulation is. Now, that's obviously not perfect, as we've learned, but they have far more information. They have supervisors on site. They approve every transaction. They have to evaluate whether an owner is suitable to own a bank. I mean, you hear from the banks, of course, it's too onerous and et cetera, but it's quite different approach than this. Aaron, I wonder, Jonathan alluded to something, but I wonder if you have any. So it seemed to me part of the issue here is that those hospitals that are doing great, like are incredibly well run, have lots of insured patients, live in a wealthy area, et cetera, they're not the ones that are most likely to get this private equity investment. The part of the problem here is that it's the hospitals like the Quincy Hospital that are sort of struggling that are more likely to get there. So is there a problem here in how we, collectively manage these struggling hospitals?
Yes, I think that there's definitely a societal problem with how to support and provide resource and capital to the struggling hospitals, particularly in rural areas, but not just in rural areas. Safety net hospitals in urban areas that are struggling as well need more resources. I actually don't know if the evidence totally bears out that that private equity specifically targets financially struggling hospitals. I think some evidence shows that that at the point of acquisition, they're not necessarily only looking at the ones that are imminently about to fail. But typically, you're right that the the sort of more higher performing, more financially stable hospitals probably have other suitors. They might
Right.
have other hospital systems or other types of buyers that are interested, that they can, they just have more choices.
Right.
Whereas,
That's what I meant.
I
Yeah.
think
they're,
you're
they're-
right.
They're desperate. I mean, we've seen this in the district.
Right. And why
Yeah.
would you sell your most valuable asset to a real estate investment trust unless that was, it's sort of like, why would you, if you own your home outright, why would you mortgage it unless you need the money? And so you're right that there's a vulnerability there. And so there's a larger question, not just in terms of seeing this wave coming before it crashes, but also figuring out how to shore up the system so that there are other forms of supports, finances, subsidies, capital, et cetera, to make sure that the healthcare system remains as sustainable and viable as it needs to be to serve these communities. And of course, we're talking about this in a time where we're facing, if anything, declining public investment and declining funding in the Medicaid program and otherwise for these critical health system needs.
So, Maureen, talk about, we need to have some rays of light here. Which is a constant struggle in Washington these days, I admit. But I wonder if you could talk about states that are doing interesting or constructive things. I think you once mentioned to me Oregon. But
Yes.
Tell me about Oregon or any other states that you think are sort of coping with this in creative ways.
A ray of light. I will say Oregon in this instance is a ray of light. They have
Even
the
though
most,
it's a war zone.
Even though it's a war zone. They actually do have the most comprehensive market oversight program in the country. A lot of states are looking to them to learn about what their implementation has been like. I mean, some of the top questions are, how much does this cost? What kind of staff do you have? But they have a market oversight program that allows them to be notified in writing, that allows
Allows or requires?
Requires them to be notified. There is a threshold, but it's well below what an antitrust threshold would be. And it is a market transaction. It's not just when there's a merger or acquisition. It's when there's an infusion of funds that reaches that requirement. They have a small staff, but they have an army, if you will, maybe small, of consultants that they can tap to do part of their review with them. They have a system where they could do a very quick review if there is a hospital or a facility that's in dire straits that needs this infusion of cash very quickly. They can do something very quick to certify that that's the case, and then they have a longer review. The state can approve, deny, or condition a transaction. I believe to date, they have not denied a transaction. They have a very public website that details all of this information. They list all of the reviews they've done. I do believe they have approved with condition in less than a handful of circumstances, and then have approvals. They do get a lot of pushback by groups in their state that they haven't done more to deny different transactions. But the fact that they can do this deep review, they review financials, they have criteria that they use. It's cost, it's quality, they use equity, and access. And they don't look at just one of those over others. They weight all of these different criteria. Those are the criteria that are important in Oregon. Other states could choose other criteria. But there's an acknowledgement that if it increases access and cost, that might be something that's worth moving forward with. They did get sued. They did move. They were successful. They have moved forward. And again, like I said, a ton of states are trying to follow them. Massachusetts has done, actually, in my opinion, quite a lot to shore up some of the gaps that they had in place. And I think Massachusetts is sort of ahead of the game anyway, because they have the they have Health Policy Commission that is an entity that does track what's going on. They have an APCD to collect data. They have
What's an APCD?
I'm sorry, an all-payer claims database that also captures other metrics of hospital financials so that they have a better picture of what's going on. One of the key issues that states bring to NASHP in trying to figure out what to do is capacity to understand what the financials that they're looking at, to be able to have the capacity to follow what's going on with Medicare cost report data, audited financial data, to help make sense of that, to understand a hospital's overall financial health. Those are usually lagging data, but it's the best that's available. And there is opportunity, should states require it, that they could ask for additional data like Oregon does during this review. But it's not an easy process, but it has been one that so far Oregon has benefited from.
John, a narrow question and a broad one. The narrow one was, Amy showed these slides showing the number of lawsuits by vendors. And so question one is that stuff that CMS gets regularly? And secondly, what is the divide, the optimal divide between state and federal oversight here?
It's a good question. The first question is not routinely. I mean, that CMS would have to seek it out, would have to go after that data. But I think you're right to point out that there is other data beyond just care processes or cost report data that the government should collect to find the clues to far more proactively react to issues. I think it's a kind of very good question to ask the question, does the federal government, the state structure work well right now? And each piece has their own role, their own function. Today, that states decide which facilities get a license. CMS's purview is to decide or to determine which facilities qualify to get Medicare funds. A facility can exist. It's hard, but they can exist not taking Medicare. So really, the state has the first determination. Does the facility meet the qualifications to be a hospital? Then there's rules that a hospital has to follow in order to qualify for Medicare funds. But that relationship is fraught sometimes. Each part may have different motivations. The federal government may want to intervene faster, but often defers to a state that's more cautious, or vice versa. The state may want to close down faster, but those roles, responsibilities are not always well defined.
Interesting. And what are the politics at the state level about your model law? What is the can you generalize about either one of you? What is it? I can guess here, but that's not my job.
So the politics, it's varied. And I know how frustrating it is to hear things like that, but it is different in every state. I would say there is significant hospital pushback to have this level of oversight. And hospitals are powerful. They are employers. They are our doctors and our nurses, but that's not who's making these decisions. It is financial decisions, it is business decisions that the state just wants to have some level of oversight over. But the pushback from hospitals is significant. The other reality is states have budgets that have to be balanced, and states don't typically, especially right now, have a lot of extra funds. We have some states that are looking at billion-dollar deficits, and they just, even if they want to have some insight over their healthcare market, they don't have the finances in order to set up even one more state FTE in order to do this work. So it's financial. It's also a general belief of what role government should have in level of oversight, period. I mean, of hospitals, yes, but of anybody doing business in their state. And it's a fair conversation to be had. But so it's varied.
Yeah. Erin, what is the role of the health insurance company in all this?
So I think that the role of the health insurance company is, I mean, it's somewhat of a different source of capital in many respects, right? So I think a lot of the large health insurance conglomerates like the United Healthcares of the world, CVS, Aetna, Humana. A lot of these players are in some ways the other big source of capital in the healthcare system. They tend to direct that capital toward the acquisition of things like physician practices or home health or other outpatients. So it's like but private equity is also targeting that sort of those types of outpatient providers with an eye to then selling it to the insurance company. And so I think one of the things that we think about is like it's a very complicated but increasingly, like as I mentioned before, consolidated market where you have a few really large actors who are kind of hashing it out in these very local markets. And so on the one hand, you think like, well, maybe a dominant health insurance provider would have some ability to push back on some of the consolidation or be able to push back on some of the quality declines that might happen in a community when, real estate investment trust strips out the assets from a necessary community provider. But oftentimes it's like that there is a dominant health insurer, or there may be no ability to sort of use that bargaining power to force markets to work, to basically say we're going to use our purchasing power as the payer to buy better healthcare and to incentivize more investment. If anything, they're just trying to acquire a different part of the stack to make money in a similar way using similar
But
tactics.
do they know that some hospital, this place must be rotten from their data? Do they know something?
I don't know if insurance companies necessarily know. The health insurance companies necessarily know who the struggling. Maybe that's a place to look, but I don't know if they know. If Medicare doesn't know or Medicaid doesn't know, I don't know if United knows. Maybe.
Right. I know there was once upon a time the big insurers were pushing people towards centers of excellence. So if you were going to get a heart transplant, they would sort of say to you, I know you like your neighborhood hospital, but they've never done one before, so maybe you don't want to be the first, and you should go to the Cleveland Clinic or something. So I don't know.
Exactly. Yeah, I mean, the payers, health insurance, the government payers, they have an incentive to help encourage beneficiaries to see services or to seek services where there's experience, where you have volume, and I think that's another sign we can look at to say, for those facilities that are performing heart procedures, what's your volume? How much do you do a year? That number is relatively small. That's a sign that there could be something wrong going on. I think that data, who's driving volume, where volume exists, can be another sentinel event to determine which facilities might need more help, support, more kind of on-site monitoring. So that is very, very valuable data.
So for either of you, has the Steward thing changed the political dynamics at all on this stuff, do you think?
Yes. I think
Explain.
I think it has elevated the awareness of how consolidation and private equity can have these, as was described, disastrous outcomes. To the point that the reporter made, like Massachusetts at the time that they approved this, from going from a nonprofit to a for-profit, again, looking at the system and worried about a hospital closing and not having any experience prior that anything like this could happen. At NASHB, we have an annual conference. 2 years ago, everyone was talking about Steward. Everybody, nobody wanted to be sitting in the chairs that the Massachusetts state officials were sitting in. And there was serious conversation about like, how do we make sure this doesn't happen in our
my
state? Yeah. And I think that's still the case. It's just, it's complicated and hard to pass these laws and to staff them.
Yeah. And it strikes me also, Aaron, that one of the problems here is that ordinary consumers are particularly poorly equipped to make these decisions. I'm certain that most people couldn't tell you if the hospital they just walked into was for-profit or not profit. Right. I remember more years ago than I care to admit, Pennsylvania for a while had really good public data about what was happening if you had a heart bypass or something, and with another reporter at the Wall Street Journal, and we went and we talked to people. Why did you get your surgery at this place, which the state of Pennsylvania says is lower quality and higher cost? And the general thing was, well, my doctor sent me there, or it was more convenient for me to go to the hospital in my town and stuff. So it seems to me it's part of the argument for government intervention, which we always should ask, is government intervention important? I'm just basically telling you that you should agree with me. It seems to me this is part of the problem here, that only the payers, the government, can protect us from this stuff, because individuals only find out too late.
Yeah, I think that there's a huge amount in healthcare generally. There's a huge amount of information asymmetry, or this like lack of knowing the information to really functionally be a good consumer of healthcare as a patient. I mean, there's so many things that are just either unknown or unknowable. Not to mention that most patients, particularly when they're sick or injured or vulnerable, are going to just rely on the referral of their doctor. Right. So I think that's, and the other thing is that we don't have a sense of most communities don't want their community hospital to disappear or to close their labor and delivery. So it's not even that there's that people haven't really made up their minds about what the community's preferences are, but it's just that they get sort of filtered through all of these like your health insurance, the entities that are making these decisions, that are negotiating these prices, and then all of these complicated corporate structures that are investing in or putting capital into the market or not. These are all sort of well beyond sort of either the control, knowledge, or ability of an ordinary patient to navigate. And so it really falls on the state and federal policymakers to protect this incredibly important asset, because once it's gone, once the hospital closes, it's very hard to ever get it back. One of the things I was wondering is what happened to the real estate, once that's been sold out from under the healthcare system. Yes, maybe the hospital can survive bankruptcy, be transferred to a different operator, but that key asset is still, being held by someone else, and that someone else can still lease it back for incredible rates.
My son was born at Brigham and Women's. I'm drawing a blank on the name. That's awesome. He was born at a hospital now, which is now condos. And we joke sometimes about see if we could rent that condo for a birthday party or something.
Right. Yeah.
Okay, your turn. As we did before, I'm going to ask you to say who you are, and we'll take 2 or 3 questions to make the conversation lively. Otherwise, I'll have to keep going. You don't want that. Pinky, another question.
Yes. Sorry, because I'm a student. I thought these conversations was really interesting. So I don't remember your name. Sorry, sir. But what's your name? John. So I was hearing about you saying, putting these healthcare providers in a risky business, right? So I was thinking, why don't the state own half of the profit from the hospital? So give these healthcare provider a basic ground to work with, and any more of innovation could work with, more financial investor. I don't know. I just putting, theoretical ideas into application. Thanks.
Yeah, ma'am, on the aisle.
I'm Maureen Lewis at Acesso Global. I work internationally, but this is really relevant to the rest of the world, as the Romanian gentleman mentioned. I have a question. We've been talking about all the abuses. Are there any examples of things that have worked with private equity or other kinds of investments that are not fraudulent, that have actually been constructive? Because we've talked about all the problems, but I'm just wondering if there is a silver lining that can be drawn or not. Thank you.
Wendell's turn. Wait for the mic, Wendell.
John, one of the things in the paper was not only the metrics, but also the hammer. I mean, what would you propose to Congress in terms of getting
a penalty structure that would make hospitals react better as opposed to this hammer.
You want to start with that one?
Well, I think we are just starting to think through how we reward quality within our healthcare system right now. And so there's been various means to give more financial incentive for better financial quality, or better healthcare quality, I should say. I think we need to think about what's the downside risk that the hospital facilities should bear for poor quality of care. I think we have tools that Congress could help CMS use better in the future for how we think about both rewarding quality but also penalizing for poor quality of care. Other means that CMS could have, that states could have, would be to take over hospital management during times of crisis. And that's something that the government doesn't like to do, but can work in certain circumstances when you see really bad situations. I do think we have to be more nimble. I do think we have to change how we use survey resources and focus more to those facilities that pose risk to the system, change our ownership, poor quality of care outcomes, but be much more comfortable than we are today to be more nimble, but even take over operations where we see tremendous challenge.
Interesting. It's almost like put the hospital in receivership, like we
Exactly.
sometimes do with housing authorities, or the FDIC takes over a bank. Yeah, it's interesting. So either of you want to take, there were two questions. One is, what about government ownership? And secondly, is all private equity in healthcare evil? So you can pick which one you want to answer.
Well, I'll answer this sort of is there any evidence that we're of private equity being a positive effect in the healthcare space? I think that there's, at this point, certainly on the facilities, so hospitals and nursing homes, all the evidence points to that private equity investment leads to higher costs, worse quality, and lower staffing. So that's not a pretty picture. In the physician practice space, the outpatient space, some of the investments that private equity has been making more recently, there's a couple of examples. The primary one in the literature right now is of chain fertility clinics, that there are certain types of large-scale investments have better outcomes in terms of successful IVF rounds leading to live birth. So there is maybe some advantage to scale and capital in certain types of services. That sort of is an outlier where we don't see necessarily the same catastrophic or devastating impact in the outpatient space. However, it's also not an unvarnished good. There's still lots of evidence that private equity investment leads to higher costs, more financial engineering, and that's a lot owing to the private equity model, which may be just uncomfortably paired with the healthcare industry. And the reason is it's such a short-term, debt-heavy investment that it doesn't actually have time to make real investments in improving quality of care or making it more valuable or more efficient. It really is just looking for these quick financial engineering strategies, which tend not to benefit patients in any way.
And government ownership of hospitals, would we be better off?
Well, I mean,
I don't want to take that.
I mean, I think that there are certainly, I think that we have to consider all of the options on the table and revisiting the idea of whether it's temporary sort of government receiver or these hybrid quasi-public, lots of states have these public hospital authorities, hospital districts, to sort of lean into these other strategies to create resource capital and supports for, again, this sort of necessary public utility type of infrastructure that we need. We probably should consider all options on the table, including government ownership or at least government subsidy.
I think there is some market for selling tax-exempt bonds is a big deal
Right.
in the nonprofit health
Correct.
insurance.
Right.
Yeah.
I was trying to duck that question, but I can also offer, like, we used to have public hospitals more so than we do now. I can't tell you, I'm not an economist, why that stopped working, but for all evidence, it doesn't seem to be working now. I will also share the system is really very consolidated, as we've already shared. Like a state taking ownership of us or partial ownership of a specific hospital, most of them, again, not all, but so many are so consolidated with other businesses, other interests, other physicians, but even we see it in org charts that we pull together, even of nonprofits, that there's just lots of other business interests, real estate companies, which are not the same thing as REITs that we've been talking about. But it would be complicated for a state to step in and say, we're going to take partial ownership of a specific hospital, given how things are set up right now, I think.
Right. And I don't think that public hospitals are uniformly seen as the highest standard of care.
No.
It depends a lot on where they are.
I think it's where you started, David, with your remarks that we have some hospitals that are for-profit that are very high quality. And so we have some hospitals in our country that are nonprofit that are really struggling. I don't think there's a really strong correlation between for-profit versus worse quality outcomes, but there are certain data points that do point to challenge and that do point to government, both federal and state, being far more nimble to intervene.
Right. We have time for a couple more. Yeah, on the aisle there.
Hi, my name is Gani Baloney. I'm a reporter for Bloomberg Law. You guys talked about the CMS and its inability to levy penalties to these hospitals that are doing these, practices that you guys don't like. But I kind of want to understand, like, why is it like an all or nothing thing? Why is it where CMS can throw the hammer down and decide this hospital doesn't get Medicare funding? Why isn't there like a financial penalty for this kind of stuff available? Is that like a statutory thing? I kind of want to get like some insight into that, because it seems like if you imposed some strict financial penalties for hospitals, then it could really solve this issue.
Yeah, I forget the precise laws, but generally the federal government can do one of two things. Number one, they can require hospitals to cure their deficiencies. So that's kind of step one. They can take action to cut off Medicare funding. It also links to Medicaid funding. But those are the two main levers that the federal government has. There isn't the kind of gradient scale that I think you're suggesting to take certain actions that fall between those two extremes. And the greatest challenge is that to really see problems, that you have to go on site. You have to walk the hospital halls. You have to look in the medicine cabinets. You have to talk to patients to really assess their care. And that requires people to do that. And for many, many years, the Congress has chosen not to fully fund the staff that CMS needs, that states need to do those surveys. We're in a shutdown right now, which means that staff that should be going on site right now, they're now furloughed. So I think we also have to think about what is the expertise that we need to go into facilities. They are far more complicated today than they were 10, 15 years ago. But really it is human beings that have to go into facilities, talk to patients, talk to nurses, talk to hospitals to really assess what is the right care being provided. We can take financial measures to get some kind of sentinel information, but at the end of the day, we have to go on site, and the Congress for many, many years has chosen not to fully fund that staff that is so necessary to go on site.
Has anyone ever proposed less draconian penalties than the ones you described?
Sure, of course, yeah, but it's not part of the process.
Can
today.
I also respond to
Please.
that question? I think that some of certainly for the sort of the huge quality lapses, John is right to sort of lay out the landscape the way it is. However, that's not in some of the sort of thinking about what could look different. We do have existing, like the Civil Monetary Penalty Statute, False Claims Act liability, which is sort of per claim scalable financial penalties that federal government and states have the ability to enforce. And actually, for some of the like financial reporting, like if you misrepresent your cost reports to the federal government or to the state, that could be a false claim, and it's been enforced as such before. So I think there are ways to, when we think about all of these sort of reporting requirements and additional transparency measures, additional oversight, to always pair it with auditing power by the state and the federal government, and the ability to bring these types of scalable financial penalties to be able to incentivize compliance in a way that is a little bit like between the do you stay open or do you shut the whole place down?
Great. Are you making closing remarks, Richard, or am I closing this? I am. One more question.
Yeah. Do systems such as the Mayo Clinic, systems such as the let's see here.
It's on.
Yeah, systems such as Mayo Clinic, Cleveland Clinic, or even the blocking on the name in California. Do those systems offer any solutions? They're very successful. Do they offer any solutions or insight into what we've been talking about? Are they models of excellence and purity?
I mean, I think if the California, you talking about Kaiser?
Yeah.
So I think that there's something to be said about, there's all of these different models of, again, I think it's not just like organizational form. It's not just that these are nonprofit or often academic medical centers that have always sort of had an engine of both educational and research, as well as the resources through a whole host of funding through training, graduate medical education, NIH funding. There's like additional resources available to these like academic medical centers. But there's a cultural there's this sense of like the culture of these institutions tends to be unique in the sense that you just can't build another Kaiser by structuring it on paper to look like Kaiser. It may not end up performing in the same way because the culture may be different. And so I think that that's why it's not as simple as simply saying, well, can we just emulate the structure or the payment models of some of these high-performing, potentially high-value health systems that seem less vulnerable to the type of financialization. I think some of these may it's not as simple as just sort of replicating it, particularly in lower resourced places that don't have the resources or the assets or the payer mix that these high-performing systems do.
So with that, please join me in thanking our panel.
I was going to clap for you guys.
Amy and her team for their good work. And I think there's more cookies outside, right? And if there's papers or cups at your seat, if you'd put them in the wastebasket, the facilities people will be nice to me tomorrow morning. So thank you all.